I'm Dr. Jim Odell from the Omaha VA Hospital, also from the University of Nebraska Medical Center in Omaha, Nebraska. And I want to have an opportunity to talk to you about our most recent work here, which is a comparative effectiveness trial comparing patients with active rheumatoid arthritis despite methotrexate and addressing a question that's been out there for a long time, that of conventional therapy versus biologics. This trial really is a strategy trial, and that's a very important concept to understand. It's not a head-to-head comparison of one therapy versus another, which you and I as a clinician really shouldn't care that much about. What we care about is giving our patients the best care possible, hopefully in an economic way. In this trial, we asked the important question of what should you as a clinician do with that patient who you have on methotrexate and they still have active disease. For the last 15 years, that question has been out there. In the mid-90s, it was shown that what's called triple therapy, the combination of methotrexate, sulfasalazine, hydroxychloroquine, is a very effective combination and is better than methotrexate alone for rheumatoid arthritis patients. Since the late 90s, it's been known that adding anti-TNF therapy to existing methotrexate is also a very good thing. In fact, we've now shown that there's 18 different therapies that when you add them to methotrexate, make patients improve. But what we haven't had until now is a randomized double-blind controlled trial that compares conventional therapy to a TNF inhibitor in that patient population. And if you look at the bottom left-hand corner of the poster, there's an outline of the trial design. Patients were randomized. They got either sulfasalazine hydroxychloroquine plus the methotrexate that they were already on, or they got etanercept plus methotrexate that they were already on. They were then treated for 6 months, and we asked the question, have they clinically significantly improved? Which I think is the question that you ask when you take care of patients in your clinic. If they had, we kept them on their therapy. If they hadn't, we switched them to the other therapy in the trial. So at 6 months, 24 weeks, patients on triple therapy, if they'd improved by a DAS of greater than 1.2, they stayed on triple therapy. If they hadn't, they stopped the sulfasalazine hydroxychloroquine and got etanercept. And vice versa, if patients were on methotrexate etanercept and they had not improved by a clinically significant amount, 1.2 on the DAS scale, they were then switched to sulfasalazine hydroxychloroquine. The whole trial was blinded, the switch was blinded, and double-blind, double-dummy placebo trial. At the end of the day, which in this case was 48 weeks, we asked the question, how much has your DAS improved? And that was the primary endpoint of our trial, improvement of DAS at 48 weeks, based upon what would your original strategy. So the strategy of starting triple therapy first, or the strategy of starting methotrexate etanercept first. I wanted to say a few words about the demographics of this trial in terms of the patients. Patient characteristics at baseline were pretty standard, and that's shown on the poster there. But there was one thing that was different about this trial, and that was that 54% of our patients were male. Now, this is the first major trial that's ever been published in rheumatoid arthritis where a majority of patients were male. Why was that? It's because this was a trial funded by the Veterans Administration. They were one of the few places where this trial could ever occur because the VA cares not only about taking good care of patients, but they care about whether or not they can do it in an even more cost-effective way. So the VA funded this trial. 153 of our 353 patients came from the VA. Hence, we ended up with 54% of our patients being male, 46 being female, a roughly equal distribution. We looked at all of our data and all of our conclusions based upon gender, and it made no difference at all. Another thing that's different about the baseline characteristics in this trial versus the standard published trial out there is that our patients were on a mean of 19.6 milligrams of methotrexate. That's the highest dose you've ever seen in a randomized controlled trial in rheumatoid arthritis. Most of the trials you've seen published have a mean dose of methotrexate in the 13 to 17 milligram range. We wanted to assure that this patient population was being as adequately treated with methotrexate as possible. So that's an important point to be made. I just wanted to emphasize that these patients then came from the VA, 153 that I mentioned. Over 100 of them, 111 of them came from the RAIN network, Rheumatoid Arthritis Investigational Network, and 89 of them came from a consortium in Canada. So it was a multinational trial. The primary endpoint, as I mentioned before, was the change in DAS at 48 weeks. And if you're following along on the poster, you nicely can see the graph. Patients rapidly improved in both groups in the first 24 weeks, and then they improved modestly in the second 24 weeks. And at the end of the day, the DAS improvement of the two groups, which was the primary endpoint again, was not different. This trial was conducted as a non-inferiority trial, and it was shown the primary outcome was triple therapy inferior to methotrexate etanercept, and the answer was no, with a p-value of 0.001. The actual delta DAS difference was an improvement of 2.12 in the triple patients, the triple strategy, and an improvement of 2.29 in the patients on etanercept. Another very important thing in the trial to understand the outcome was the switch rate. We didn't know, of course, when we planned the trial exactly what the switch rate would be. And we realized that if the switch rate was widely different between the two groups, that people would interpret the primary outcome in that context. The good news in our trial was the switch rate was identical. 27% of the people switched from etanercept to triple therapy, and 27% of people switched from triple therapy to etanercept. It was surprising to us that it was identical, but that was what we found. So 73% of the patients in both groups continued on their original therapy for the second 24 weeks of the trial, and the graph that is just below the primary outcome graph on the poster shows those groups now broken out by those groups that continued on the original therapy and those who switched therapies. That part of the study showed a very interesting thing. Of those patients who needed to switch, both of those groups, both the groups that switched to triple and the group that switched to etanercept, got significantly better. With a p-value of 0.001, and the improvement in one group over the other group was not different. They started at the same DAS scores, and they improved a similar amount in both groups. So that's the first time you've ever seen data that looks at a group of patients who have failed triple therapy and then got etanercept, and the answer is they get better. It's also the first time you've seen data where that shows that when you fail etanercept, you do better with triple therapy. So a number of other ways to look at the outcomes, of course, would be looking at the DAS28 changes and obviously, importantly, the radiographic findings. And so I want to go to the radiographic findings, and those are shown on our poster on the upper right-hand corner of the poster. And very importantly, the radiographic progression in these groups was not different. So that was a major secondary outcome, primary outcome in the delta DAS, as I mentioned already. And what we found in this trial is that at baseline, the patients in the triple group had about 20 sharp scores points, and the patients in the etanercept group had 16, so a little bit worse in the triple patients. But the progression was almost non-existent in both groups. Remember again that both groups of patients are treated with proven effective therapies, and if they don't do well, they have the opportunity of receiving another proven effective therapy. So as you can see on the radiographic table there, the the total sharp score progression of the triple patients was half a sharp score, and the total progression of the etanercept patients was a quarter of a sharp score. And those numbers were completely identical statistically. And more to the point, in the lower right-hand corner, right before the conclusions, is a nice graph that shows you the cumulative probability plot. And you can see they're completely superimposable. So there's no radiographic difference between the strategy of starting triple therapy first versus the strategy of starting methotrexate or etanercept first. Again, we think a very important point for clinicians. Now, many people have asked us, why did we choose 1.2, improvement in DAS, as the switch point? There's a number of different things we could have chosen. We could have chosen an ACR 20. And if we chose an ACR 20 improvement as the switch point, the switch rate would have been also identical. It would have been different. It would have been 44% for both groups, but it would have been identical from one arm to the other. We would have had more people switching and getting this other therapy, but the switch rate would have been identical. Some people say, why didn't you choose a DAS 28 of less than 3.2 as a switch point? And the reason we didn't is because we don't believe that's what clinicians do in clinic. We believe that in clinic, patients and physicians ask the question, have I clinically significantly improved, which is defined as a DAS of 1.2, and that's when they switch therapies. If we had chosen the DAS 28 of less than 3.2, our switch rate would have been different. We would have had 65% of the patients switching off of etanercept, and we would have had 75% of people switching off of triple therapy. So we would have had more people at the end of the trials, marginally more, on etanercept than triple therapy. The results, however, of our trial would not have been different. If you believe that etanercept is marginally more effective than triple therapy, the end results of our trial would have been even more similar than they were. If you look at our 24-week data, some of which I've just alluded to when I talk about switch point, there was a little bit faster response to the etanercept than there was to the triple therapy. But at the end of the day, again in our trial, at 48 weeks, it did not make a difference, both in clinical outcomes, DAS 28 responses, and in terms of radiographic outcomes, which of course are the SHARP scores that I've already mentioned. So in summary of our trial results, in rheumatoid arthritis patients who are on methotrexate, in this case with a mean dose of almost 20 milligrams, if they're started on triple therapy, they do just as well as if they're started on etanercept, if they have the option of switching at 24 weeks if they're not doing well. The switch rate, again, between one strategy versus the other was identical, 27%. Further, the SHARP score progression was very similar between the groups. Half a SHARP score progression for the triple patients, a quarter SHARP score progression for the etanercept patients. Finally, patients who had an opportunity to switch did better in terms of after their switch. And that was true whether they had failed etanercept and got triple, or whether they had failed triple and got etanercept. Both groups improved significantly. So we have shown that the strategy of starting with conventional combinations first before etanercept is a valid strategy and gives you equal results as if you went the other direction around. Obviously, this has significant cost implications as triple therapy is considerably less expensive than methotrexate etanercept. One of the important questions to us as clinicians is always, what were the adverse effects of any of our therapies? In this trial, we had assumed that we would see a few more adverse events related to minor toxicities, GI upset, those kind of things from triple therapy, and we might see a few more serious infections from etanercept. And in fact, that's exactly what we saw. Overall, the toxicity of these two different therapies was very similar. The withdrawal rates were similar across trial. the tolerability measured by what percentage of the medications they took were essentially identical from one therapy to the other. But we did see a few more GI toxicities, mostly nausea, that type of thing, from the methotrexate, sulfasalazine, hydroxychloroquine arm. And we saw a few more serious infections with etanercept. Most of those ended up not being a big deal. We did have one death from a pneumonia in a etanercept patient. We had a patient who had a serious sinus infection, fungal sinus infection from etanercept, or at least in the etanercept arm. And we had another patient who had pulmonary aspergillosis while receiving etanercept. Clinicians often ask us, what do the patients prefer? And the formal answer to that question we don't have, because we did not do formal surveys on what patients would prefer. Of course, in this study, we asked a lot of the patients. They were taking not only the pills, but they were taking the shots. I remember the design was a double-blind, double-dummy. What we can tell you is that we had terrific compliance with patients in both groups, and the compliance measured by the percentage of the medication that they took in both arms was identical, 79% in one group, 78% in the other group. Additionally, we can tell you, as I did earlier, that the toxicities were not significantly different. A few more nuisance toxicities with the triple therapy, a few more serious infections with the etanercept. So patients in general are going to be happy if whatever they're taking is making them better. And that's really been shown in all the combination trials that have been done, particularly when they've been done with conventional therapy. Triple therapy trials have always shown that the people in the triple arm actually have less toxicities and better tolerability than the people in the single arms. And we believe that's because they're feeling better and their disease is under better control. So overall, both therapies were tolerated very well. Some might ask, with the findings of our study, which have shown that the strategy of starting triple therapy first is identical to the strategy of starting methotrexate etanercept first, are there situations where we would ever use etanercept or a TNF inhibitor before we use triple combination? And the answer is sure. No study, certainly not this study, can ever replace clinical judgment, and we don't want to take that out of the equation. So there are times, I think, when clinicians would have some kind of a feel one way or the other. Additionally, there are situations where people may have sulfa allergies, and patients don't want to start sulfasalazine. There may be issues where patients have macular degeneration problems, or they have issues that they're deathly scared of a drug where they have to get a baseline eye examination like hydroxychloroquine. We know hydroxychloroquine is incredibly safe, but again, there's patients that have some of those fears. So clinical judgment is always going to be important, and there may be clinical situations. However, in general, with what we have shown, the preferred strategy to spend our healthcare dollars wisely would be to start triple therapy first. That way, about an additional 25% of patients will be well controlled, will get very adequate control of their disease without having to go to the biological therapies. One of the important questions that people will ask is, can we generalize what we've shown in this study to other TNF inhibitors, or for that matter, to all biologics? And the answer is, in a scientific way, no. We've studied the combination of triple therapy versus methotrexate etanercept, so all we can really say for sure is that we're comfortable with those results. Certainly, most clinicians feel that there are similarity of response to TNF inhibitors across the whole class of TNF inhibitors. So we believe that in some ways our results can be generalized to other TNF inhibitors, but we have not done that trial. So in strictly speaking, we can't do that. Further, we certainly cannot generalize our results to the biological DMARDs with other mechanisms of actions. Abatacept, rituximab, tocilizumab, we've studied etanercept, a TNF inhibitor. There are trials that show overall the response to abatacept and TNF inhibition, are roughly similar, but that doesn't mean we can necessarily generalize our results to all biologics. Usually, when we have a patient who has failed methotrexate, the first option for the clinician in their mind is to start a TNF inhibitor, and that's why we've studied that class of medications, and we believe that that would be the preferred strategy before moving to a biologic, even though we can't and don't want to imply that we have compared ourselves head-to-head with other biological DMARDs.